Hi, my name is Mark Lubitz, and I'll be guiding you through this week's medical research update. First, we have an article reviewing the mosquito-borne flavivirus yellow fever, which is present in sub-Saharan Africa and parts of tropical South America. A vaccine for yellow fever was developed in the 1930s, but to this day, we still have 180,000 cases per year, leading to 78,000 deaths. The vaccine is still made in embryonated chicken eggs like it was in 1930. So the authors of this article think that we should update the practice to be consistent with the way we make other current vaccines, so that way we can increase the supply and make it more feasible to spread this vaccine throughout the areas where it's endemic and hopefully stop the outbreaks of this virus. The next study is an exciting one comparing the effects of liraglutide to placebo in addition to standard of care therapy in type 2 diabetics, measuring their cardiovascular outcomes. The rate of death, MI, and stroke were all lower with the GLP-1 analog liraglutide compared with the placebo. Liraglutide has also been associated with decreased weight and blood pressure and increased heart rate and incidence of gallstones. Overall, it appears that adding liraglutide to standard of care therapy for type 2 diabetics is a promising treatment strategy to help prevent cardiovascular disease. Next up is an article with some more good news for diabetics. This is a study investigating the drug empagliflozin on the progression of chronic kidney disease. A major trial came out recently that studied the effect of empagliflozin on heart disease and recognized that it decreased the risk of heart disease in diabetics. Now they're looking at the effect on the kidney. Empagliflozin inhibits the sodium-glucose cotransporter in the kidney, forcing you to excrete more sodium and glucose, thus decreasing your blood sugars. And this study showed that it also decreased your risk of renal disease and kidney failure. In summary, when adding empagliflozin to the standard of care in type 2 diabetics, you can expect a decreased risk of cardiovascular disease and a decreased risk of chronic kidney disease as compared to the addition of placebo. Next, I'm going to talk about a big review article that came out this week on the treatment of opioid use disorders. Opioids were intended to decrease pain, decrease cough, and decrease diarrhea. However, they also can induce a euphoric state and increase tranquility, which provides anti-anxiety benefits to patients, thus making them drugs that are commonly abused. In the United States alone, 400,000 people have used heroin in the past month, and over 4 million people have abused prescription painkillers. This has led to over 17,000 deaths per year. 3 million people in the United States and over 16 million people worldwide have had opioid use disorder at some point in their lifetimes, and it's estimated that an astonishing 11 million life years have been lost to opioid abuse. Like many diseases, opioid abuse disorder can come and go throughout a person's life, but the underlying vulnerability never leaves. In addition to the increased risk of death from respiratory depression, opioid abuse disorder increases the risk of infections like HIV and Hep C substantially. It also increases the risk of legal issues. Abrupt cessation of opioid use can precipitate immediate withdrawal symptoms, which can be very, very rough on the patient. Treating these symptoms has led to better outcomes and will facilitate a bond of trust between you and the patient, thus helping long-term opioid abstinence. Some of the major signs and symptoms of opioid withdrawal include tachycardia, pain, diarrhea, massively dilated pupils, restlessness, tremor, and many others. Acute withdrawal is followed by chronic withdrawal symptoms, which include anhedonia, decreased appetite, insomnia, and fatigue. It's been shown that the most effective treatment of opioid withdrawal is to use a long-acting oral opioid like methadone, and then to taper it down to zero eventually. You can also just treat symptomatically with drugs like clonidine, an alpha-2 agonist, which will decrease the sympathetic kind of symptoms, benzodiazepines to decrease insomnia and anxiety, Imodium for the diarrhea, NSAIDs for pain, and then Zofran for nausea and vomiting. Combining cognitive behavioral therapy, motivational interviewing, naltrexone, and long-acting opioid tapers like buprenorphine and methadone have been shown to be the most effective way to treat opioid use disorder. Overall, treating opioid use disorder is extremely complicated and has to be tailored specifically on a case-by-case basis. However, using the combination of cognitive behavioral therapy and pharmacotherapy, morbidity and mortality can be greatly reduced. That's all I've got this week. Tune in next Monday for more.